And now we are at the flag end of our workshop. And for that, we have Professor Nandini Chatterjee, madam, with us. Professor Nandini Chatterjee, madam, is the scientific chairperson of API West Bengal branch. And welcome, madam. And currently, madam is professor at the Department of Internal Medicine at IPJMER and SSKM Hospital, Kolkata. Also, madam is the chief editor of Bengal Physician Journal. So, welcome, madam. Along with that, we have our esteemed panelist today. I think I can see Professor Nandini Kumar, madam. Welcome, madam. It is our real privilege to have Professor Nandini Kumar, madam, as we had introduced her. Madam is currently the president of FARSI, Forum of Ethics Review Committee of India. Madam was one of the pioneer in developing this ICMR guideline, what we actually read, what we actually give references. So very welcome, madam, once again. We have with us Dr. Sucheta Banerjee Kurunkar. Already we had introduced madam, and madam had delivered a fantastic lecture about the role of investigators' responsibility. So we'll be happy to have to take your opinion, comment also, madam. Welcome. We have Professor Santanu Tripathi, sir, Dr. Shantha Selvarajan, madam, and also Professor Avijit Hazra, sir, who had delivered his talk and we had introduced him also. So welcome, Professor Avijit Hazra, sir, Dr. Shantha Selvarajan, madam, Dr. Sucheta, madam. So now may I request Professor Nandini Chatterjee, madam, to start the panel discussion, and the questions you can ask and you with your insights. Over to madam.
Thank you very much, Shambho. It is the enthusiasm of our very dynamic Dr. Shambho to organize this GCP workshop, which has become mandatory for all scientific people to have an idea about to maintain quality control of carrying out clinical trials. So firstly, when I had a look at the chat box, I see that there are no questions as such. I think people have really been benefited from all the lectures from our esteemed panelists, but still, I would be clearing certain aspects or issues with our esteemed speakers. We have the good fortune of having them all under one roof sort of today. So firstly, I would be coming to Madam Professor Nandini Kumar. Good evening, Madam. So for our listeners, would you like to comment on how the ICMR 2017 guidelines ensure an ethical balance between promoting scientific advancement and protecting vulnerable populations in clinical trials? Your comment, madam.
Well, vulnerability was actually addressed in the earlier guidelines also. First revision in 2000, second revision in 2006. But it was expanded to a great extent, so it became a separate section by itself. And vulnerability is something, you can keep on talking about it. It, of course, is because of lessened capacity to, take a decision due to various circumstances. And when this each section actually had a committee. And this particular section had lots of activists in that group. And there were actually at least 3 A4 size paper full of, type of vulnerabilities, people. So, you can't have it in guidelines just like that. So it was very difficult actually to group them. And while grouping also, there could be overlapping. For example, if age conditions, if you take the elderly at the mercy of their children and the children being at the mercy of their parents, so they can also be in the lower socioeconomic group. So this could be an overlap, which is actually difficult, when you try to classify. And when you are actually on the real ground, you see this overlapping among the participants. So how do you actually evaluate? There was once a question, actually in one of the Kolkata premier institutions, where we had gone for a survey. And it's a cancer institute. And cancer patients are vulnerable anyway. So how do we see, I'll just give you an example of the understanding. For example, same sort of institution in Mumbai, they said that they don't write anything about vulnerability. So when you say that, why don't you actually write anything about that? Your patients are all vulnerable. They said, no, we don't consider it because everybody is vulnerable. So that doesn't mean that you should not comment on that. And for the Kolkata institution, of course, they recognized that. But, how to balance that? Because everybody is vulnerable. So one of the lead surveyors, an international figure, she said that I would consider stage 1 and stage 4 difference. So relativity is the criteria because of which you should actually take your decisions. So that's about vulnerability. I think you mentioned something else. So other clinical trials, you have to be doubly careful about that. But I must say that the regulated clinical trials are better off because you have a good oversight mechanism. And if you don't abide by that, also there are mechanisms to catch you. But this is something very difficult in the academic trials or
Yes.
biomedical and health research because we don't have a proper monitoring mechanism. So that's where
This
we
is the, yes, madam.
suffer.
And this is the reason why regarding, there are very less studies who are really dealing with the geriatric population who are much older. People who are more than 80 years, there are very few studies because there we have to consider all these factors to safeguard the vulnerable population. In that count, to some extent, I feel that science is also sort of suffering because we can't have trials with them. And we actually don't know how they respond to therapies or what is the disease process going on in those groups of patients. So this is actually a doctor's dilemma or the researcher's dilemma, how to balance.
So
Thank you.
earlier, I remember the drug trials,
Yes.
the regulators' drug trials, they used to
Yes.
restrict the age up to 65. Then the
Yes.
question came that what about the elderly, more elderly who are suffering from those types of diseases which affect them? So then this was relaxed, actually. And slowly, many ethics committees I've seen which have taken this into consideration. If it is really for the good of the elderly, they don't go in for that argument that why do you want to take elderly? But then you can't have this, 18 to 80 age group. That is too wide a range. And what sample will you get for analysis? So these are the things actually from the ethics committee point of view we have to see.
Yes, yes. Thank you, madam, for your insight. Now, I'll be coming to Dr. Sucheta, madam. Madam, is she there? Dr. Sucheta?
Yeah, hi ma'am. Good evening. I'm there
Hello.
actually suffering from some network outage. Yeah, outage because
Okay.
there's a
So
heavy
the
rain
video
last
is
in this
off.
place.
Oh, it is
But I can
fine,
hear
madam.
you, ma'am.
Yeah.
Yeah.
So, how should researchers ensure true informed consent in populations with low literacy or if they have some language barrier? This is a real problem actually when we are dealing with, we are having studies with rural populations or slum dwellers, and we have consent forms with quite complicated languages or many things are written. So what is, madam, your comment about this? I think we've lost Dr. Sucheta Shambo.
Hi, ma'am. Actually,
Oh,
I got disconnected the moment I switched on the video. Sincere apologies. You were telling something. I switch off the video
yeah, I'm
again.
saying that how do we ensure true informed consent in populations who have low literacy or there is a language or cultural barrier? This is a very frequent thing that we encounter when we are having a study population which may be rural or coming from the slums, and the consent forms are quite complicated. What is your comment about that?
Yeah, thank you, ma'am. This is a very interesting and very important question because here is the problem of assumption, because a doctor or an investigator might have very less time and may assume that he or she has described the entire scenario of the clinical trial and the participant has understood, but the participant may misconstrue it as a treatment and not as a part of a trial. So it's very important that vernacular language, some flow chart, also taking a read back from them that if I have told you this, what you understood. And I
Understood.
personally feel that recording, am I audible? Am I audible?
Yes, madam. Yes.
Yeah, I feel here the recording actually plays a role because if I am a participant and today I have agreed to be a part of a clinical trial and I may be not very literate person, tomorrow I might change my plan, and I may go against by saying that the investigator has told something else. So there must be some documentary evidence which is at the level of that person, whether it is tribal, whether it is any kind of challenge, whether it is education or social social factors which might stop person to get a full acquaintance of that. I'll give you an example of myself. I was a clinical trial participant myself, and I now when I studied clinical trial, I realized that I was assumed and I was taken for granted. So even a literate person is also can be a guinea pig syndrome. I still feel that I was a guinea pig in the trial. So even literate person can become, and such can be the case of or people who have literacy or kind of from a different socioeconomic status. They are more difficult to handle. So there must be some kind of assurance, read back, making it simpler, asking from them, recording it in their vernacular languages. There can be many other mechanisms. There is a Nandini ma'am is here, and Nandini ma'am used to always show one book which was called a reading book, and that book was discontinued, but that was a very interesting book where it was in different languages, where you give it to the patients and the patient used to see that and understand the entire process. Some kind of thus mechanisms is required, and it has to be customized depending upon how the situation is. Thank you, ma'am.
Okay. Thank you. Yes, it is what you have said is very relevant, that there should be evidence that the subject has understood the investigator. So recording and taking feedback, as you
Yes, ma'am.
have
I would
said.
like to correct. I would like to correct participant, ma'am, because subject is the word
Okay.
which has which actually, yeah, in medicine we might use, but for clinical trial, I think we should stick to
We
participant
shouldn't.
because
Okay.
participant
So
gives
it
us
will be
an equal, yeah,
participant.
equal right, ma'am. Yeah, yeah,
Okay.
ma'am.
Okay.
Thank you. Thank you.
Okay. So uh, moving on, we have with us Professor Santanu Tripathi, and sir has always been a great teacher and has cleared our doubts time and again, sir. So I'll come to you for the next question, sir.
Yeah, I'm there.
So ICMR 2017 mandates that there should be compensation for research-related injury. Now, how does this affect sponsor accountability, and what are the challenges in implementation at a institutional level?
So when you talk of the industry-sponsored regulatory clinical trial,
Yes.
there are not much challenge. In fact, it is very well laid down, and the relatedness assessment of the serious adverse event, that is also to be done as per the rules. The Rule 39 of the New Drugs and Clinical Trial Rules 2019. So that guides us to decide the relatedness. And once it is found to be related, then the injured person is entitled to compensation. And the sponsor has already indemnified the investigator as well as the institution. And the sponsor usually goes for an arrangement for insurance, whereby the insurance company would be making the payment. Okay. And it is very straightforward, and the amount of the payment or amount of the compensation is also decided by the formula. If it is death, there is one formula. If it is non-death serious adverse event, there are other formulae. So it is well structured. Only problem area in case of regulatory clinical trials is medical management, cost of medical management. So until unless the relatedness assessment is done at the point of time when any serious adverse event has been encountered and has been reported, it becomes the responsibility of the PI and the study team to ensure that the person, injured person, receives medical management without any out-of-pocket expense on his or her part. But the usual practice is the industry wants it to be reimbursed. But I personally feel in Indian context, this reimbursement clause is anti-patient or anti-participant. Okay, if a poor trial participant who is participating, if you ask him that you spend from your pocket and I am going to reimburse,
and I'll reimburse later, that is not feasible.
It's not. It doesn't work really. So, and it is here where there is a. This is a weak point. Okay, in thing, and I think the investigators should be conscious about this. An investigator, before the study starts, trial starts, investigator should negotiate with the sponsor and get some kind of seed money. Okay, so and that, from that the investigator can make the payment, and later on that can be adjusted. If it is found it is not related, then from that point it becomes the responsibility of the study participant to take care of the expense, etc. Now, problem lies in case of investigator-initiated trials, okay, where it's not clear who is going to pay the compensation, because our academic clinical trials, the investigator doesn't have a long pocket, so that from there they would be paying the compensation. The Ranjit Roy Chaudhary committee long back had suggested that there should be a corpus fund which can be created by the institution, local institution where the trial is conducted, or the university, or the local government, or the central government, or the funding agency, etc. But then that has not happened. In reality, it is again a weak area, as a result of which the academic trials are either not happening or happening in a veiled manner. Actually, people are doing trials, but they are posing as if they are doing observational studies, which is very, very wrong. But recently, only recently, for the last 1 year, the matter has been taken in the right spirit, and ICMR is developing a guideline. Okay, although in earlier guideline, also 2017 guideline, there was a mention that there cannot be any double standard in academic trial also. The participant, if he is injured and if it is related SAE, then he is entitled. But then now probably a more clearer guideline on these issues are going to come maybe in another few months or so. Let's wait until then. But then at the same time, things are changing very slowly though. Like ICMR has now always encouraged that ICMR funded projects, if it involves a clinical trial, while we are planning it, we should also in the budget, we should keep a component of compensation. Okay, and then you have the money with you, then you can go ahead. And we remember during the COVID time also, our experience has been that we could get some compensation support from the government of West Bengal also. And at least personally, I conducted one trial where we could get the money from the government with which we had paid the insurance company. Okay, so it's not impossible if one tries. So this is an area. Thank you.
Thank you, sir, for clearing out this issue about how we should be responsible and accountable for research-related injury. Now, we would come to Professor Sandhya Selvarajan, madam.
Yes, ma'am. Yes.
Yes. So, we would like to know, given the central role of the ethics committees in trial approval and monitoring, how effective are the current measures to ensure their independence and transparency as per ICMR 2017?
Yeah, that's a good question. So ICMR has given guidelines for having a common ethics committee for multicentric trials and how this ethics committee can give suggestions, but still keeping options for giving options for the other site-specific ethics committee to give their suggestions, and the site has to go as per the site-specific ethics committee's suggestions. Though this is in existence, at least from my side, from our institute side, so far I haven't come across any study where there is a central ethics committee following central ethics committee's approval. The study has been the study has come to the local ethics committee. I have not come across such a thing. So multi-centric studies with all the sites ethics committee approval, it is happening. I'm not sure of the studies. There may be some studies which I am not aware of where with central ethics committee approval and it is coming to the local site ethics committees. However, with respect to homeopathy, there is such things are happening. There is a central ethics committee which is giving approval. With that approval, it comes to the local ethics committee. Though they are also accepting local ethics committee's suggestion, but most of the things they would have reviewed, and the work is less for the local ethics committees to comment on. But as far as our modern medicine studies are concerned, I have not come across such a thing. So I am unable to comment on it. Maybe like if Shantanu sir or if
Yes,
Nandini madam
Shantanu
is
sir
experienced with
is
respect to this, they can add to this.
Sir, would you like to add to what madam has said?
Yeah, she is very right.
And Nandini ma'am is also there. I'll be also asking her regarding this. Okay, sir.
This concept of central ethics committee really had come up when particularly it was felt by ICMR, because many of the multi-center projects of ICMR that suffered because the local ethics committee were taking a lot of time, okay, in providing their approval, etc. So this thought came that whether the primary center which conceived the idea and developed the protocol and got it approved by at his center, whether that can be taken as a kind of catalyst, okay, for facilitating approval by the local ethics committees. So that's how things are now moving, that until unless there is a very serious issue, that the local ethics committee is not going to otherwise uh, not approve or delay the approval or asking for relatively minor things, etc. So that is basically to facilitate the early initiation of the study of a multicentric study, which is otherwise supported by ICMR. Apart from that, there is also at the headquarter, ICMR headquarter, there is ethics committee. But most of the time, that ethics committee has only a initial consideration about the ethical issues and thereby guiding how the protocol can be further refined, etc. So that still is existing. That has actually helped to a great extent during the COVID time, wherein the many such multi-center studies were conducted, and the central ethics committee, so-called central ethics committee in the ICMR headquarters, that also helped. But then the general spirit is not to dilute the importance of the local ethics committees or the institution ethics committees. So they have their freedom to consider local issues. Many a times, local issues are many a times important, and that has to be also given proper consideration. That's it. Thank you.
Madam, Nandini, madam, would you also
Yeah,
like to comment?
actually, I was the secretariat, ICMA secretariat person for the Central Ethics Committee on Human Research at ICMA headquarters. It was not dealing with multicentric trials as such, but if there was any issues arising out of that of national importance, or there was some policy matter involved, then only those proposals were actually reviewed by that. But then later, when COVID came, then, it was reconstituted to see all COVID proposals in the country. So, just so the nature changed. And then I understand that ICMA headquarters proposals also were seen by this Central Ethics Committee. When it comes to drug trials, actually, what was given in the ICMA guidelines was for low risk, multicentric trial with low risk, only those would be taken up. But in 2020, the guidelines opened it up for, more risky area like COVID. So it was not low risk anymore. So it was more risk. But still that philosophy persists. And what, as Sandhya had mentioned, in the traditional system, in Ayush institutions, I think this is taken up more seriously. And I myself have conducted a study where, not conducted a study, I have chaired the ethics committee, which was actually the designated. What we say is there are 10 centers. One ethics committee is chosen as the designated ethics committee. And this ethics committee has to take input from all the site ethics committees and, finalize the master protocol. And this would be followed by the site ethics committee without losing their responsibilities or their jurisdiction. Either they pass it through expedited review or they just accept it as such. That was the philosophy, and I followed that. For the Ayush proposal, we had other centers. So our center was designated probably because I was chairing the committee, and we had the chairperson and the member secretary of the site ethics committee. And we said that if other members also can attend, well and good. And their inputs were taken, the protocol was finalized, and then this protocol went to the sites for them to follow up about their role, about, managing the site activity.
Okay, thank you, madam. So, Avijit sir is also with us, Professor Avijit Hazra. Professor sir is here. Yes. So, another aspect that was dealt with today was community engagement. And here, we would like to ask, to what extent do the guidelines promote meaningful community engagement and ensure that research offers tangible social value to its participants and their communities? Sir, your comment.
You've asked me a difficult question because whatever studies I personally have been involved in or what I've been overseeing, mostly these have been hospital-based studies rather than community-based studies. But nevertheless, from whatever little experience I can have, we say that community engagement is very important in certain kinds of studies. Vaccine studies come to my mind at this stage. And also some, not necessarily drug-related studies, but some, say, nutritional intervention-related studies. These have usually to be carried out in a community setting. Now, working in the community is quite a bit different from working in hospitals. Firstly, investigators have to go out to the field and make contact with participants within their community. So there are issues of vulnerability, there are issues of language and cultural barriers, there are issues of community leaders. Usually in closely knit communities, for instance, in certain rural communities or certain tribal communities, what I gather from researchers who have worked with these in these settings, that engaging the community leadership is very much important, taking them into confidence and through their mode, through their help, approaching individual potential participants. So often they have to engage in initial, say, meetings, group meetings or camps to discuss these situations. And I also think this is very important if you look at from the participants' perspective. So they are encountering researchers who may be coming from institutions where, which may be in cities in which they have no contact with these institutions and such. Then they are proposing certain interventions or certain observations to which again they may be being exposed for the first time. So in these studies, number one, community engagement, either directly with the participants or through community leaders, is very, very important. And respecting community sensitivities, community cultural norms, even the times of visits are important. So what I gather from some of my colleagues who have worked with, say, rural population, if you go in the normal working hours, in the mornings, for instance, you'll find that it's very difficult to get the participants because they're out working in the fields or whatever their occupational settings are. So you have to time your visits according to their convenience. In hospital, it is the opposite. You ask them to come as per your convenient date and time. Here it has to be opposite. So you have to take into account these things there. So time of day, the dates, you have to avoid local festivals, ritual dates, etc. All those things are there. Again, the way to work around these difficulties is to engage with community leaders or some of the senior members of the communities, take them into confidence, and that way you can get your studies done. Regarding adverse effects of interventions at the community level, fortunately, most studies which go out in the community, they are not doing very critical interventions. So you won't find, let's say, anti-cancer drugs or immunosuppressant drugs being tried out at the community level. Maybe this would be studies related to vaccines, studies related to hematinics, which are getting done at the community level. So I can't say that I'm experienced about managing adverse effects and serious adverse effects at the community level, but the same pharmacovigilance mechanisms, the same monitoring mechanisms would apply in whatever setting you're working.
Yes, sir has touched upon a very significant thing about working in the communities. And first thing that we have also seen when we were not randomized trials, but we were actually currently carrying out an observational study, a surveillance in the community. And it is very important for the people to feel that this study is going to help them in some way. It would benefit them in some way. Otherwise, the people who are going out may face some adverse behavior from the families or community as such. So
That's
this is a
exactly
very
the point. You
fine
have to
balance.
make them
Yeah.
feel that it is their study rather than it is your
Yes,
study.
yes, rather than
And-
our scientific endeavor.
Yes. And that doesn't
Yes.
happen on the first day. You'll have to go out and reach them
Go
on
on, yes, it requires patience and time and lot of involvement on the part of the investigator as well. So thank you, sir, for your comment. And now we have really come to nearly the end of our discussion, and I will again come back to Professor Nandini Kumar, Madam. Madam. Yes,
Yeah.
yes, madam. When we are on the issue of benefits, which are the result of all these endeavors. So ICMR 2017 highlights the post-trial access to interventions and how realistic is this expectation in trials sponsored by private entities? And what mechanisms can be adopted to ensure a fair benefit sharing?
Very important question. You know, we had been writing this in the 2000 guideline, 2006 guideline, 2017 guidelines. By 2017, it became more and more important because when it was discussed in ethics committee, many times, you know, they used to have a frown on their face. Now, how do we solve this? Let us just skip it. That sort of attitude, no? But then when in 2019, the NDCT rule came and it became mandatory to observe this post-trial access, then some more seriousness has come. I always tell people that benefit doesn't mean that it has to be money, you know, it can be in kind. For example, you have a diagnostic kit which has come out. It has a commercial value and all those things. What are these participants who are going to gain from that? So they should be given something. So you need not give them money. Now, if it is genetic testing or pharmacogenomics, it's not the individual, it's the family which is affected. You can say that the family members of this person coming to this institution will get a free testing done. Something of that sort, you know, I mean, you can always create a policy which will benefit them. So each circumstance is different. So you can actually devise that accordingly. And we used to even argue for the drug trials where stents were being used. You know, always these sponsors, you know, they will come under the guise of observational study. And then why should the person actually pay 5 lakhs or something like that for their observational study? They have a market value and they are going to benefit. Shouldn't they give it back? So either it was refusal or the sponsor will come back saying that, okay, we will give for 2 lakhs because otherwise it's not feasible. Like that, you know. So you have to negotiate, actually. And if they don't listen, don't approve the trial. Just reject it.
Yes, ma'am.
But
This
at
was a
academic, I do understand at the
very
academic level, it is rather difficult because institution will have to take a stand. And there also we can make out some policy, you know, like I said, free testing for the family when they come to the institution, something like that.
Yes, madam, very wisely commented. Here is one question, though not related to this question. Dr. Anjali Bandopadhyay, she asks that how the fund is to be transferred from ICMR to sites in multi-centric trials, whether it is in personal account of PI or office account of the site. So, madam, would you like to answer this?
It will not go as a personal account anyway.
Yes.
Because you have to give a statement of account and things like that. So it will go
Yes.
through office only. Some
Office,
institutions
yes.
have research cells dealing with only that, like AIMS and all that.
The
So
MRU.
go there. I mean, it depends on the policy of the institution. It goes to the
Institution.
administration from where it gets released.
Thank you, ma'am. There was another question by Dr. Orko. However, I think Dr. Tripathi, sir, somebody has answered it. I think Dr. Sricheta has already answered it. So, Shambho, I think, are there any more questions? I don't see in the chat box.
So, no, madam, I don't think
There
there is
are no
more question.
questions.
So,
So, in that case, I think
No,
I
let
will.
me
Okay,
come
sir.
in and leave the whole event with a question. Let the participants also put their head into it. When you talk of benefit sharing, whose
Yes.
benefit you are actually referring to? Do you actually mean the participants' benefit? Okay, or benefit sharing in terms of the community where the trial is being conducted?
Yes.
Okay. Truly speaking, for a
It-
participant, there
It
is
means
hardly.
both. It means
Yeah.
both, actually.
Yes.
Now, when you talk of
Participants need not be
right,
those who are coming to the institution. They can also be community, public
yeah,
health. research.
Right.
For example.
And truly speaking, when you talk of direct benefit, that means if I am participating in a clinical trial, okay, as a participant, it's the benefit of the participant is not the prime objective of the trial. So it is while the participant is always at risk, there might be uncertainty of the intervention. Okay, the intervention might not act. Okay, we want to be sure about whether it would act optimally or not. That's why we are conducting the trial. But then risk is there that the patient, the person, the participant can get injured. Okay, can suffer from, can experience adverse events. So while the risk is always there, the benefit is not that much. So whenever we talk of benefit sharing with the participant, mostly it is indirect benefit. But after the trial is over, we actually, when we say benefit sharing, we actually mostly we talk about sharing of benefit by the community where the trial is happening. Like if you think of the global clinical trials, this is here where the benefit sharing probability is very low. Whether or not the company would be applying for the approval, marketing approval in that country, it is their choice. No regulator can compel any sponsor to get the drug into their market. But then global trials are happening. So that way, it's a difficult concept actually, benefit sharing. And we need to put a lot of thought into it. It's evolving. It is evolving. Benefit sharing concept is evolving for that matter.
Actually, what I would say is there is something called access and benefit sharing, ABS, which has been actually propagated for all those research where you have a potential commercial aspect. Only in those you can talk about that. Then about that, I agree with Dr. Shantanu about the indirect benefit, but not only to the participant, to the society as well. And that's why we write in the under the benefit thing, you may or may not benefit from this, but the future patients or the society may benefit. There also you are putting only the word may, because you are not sure at that point of time whether it will be beneficial or not. But there is direct benefit also, because patients who cannot have MRI or CAT scan or whatever investigation otherwise get that done through the investigation. That is the direct benefit.
Some benefit is
And
there.
also for genetic testing and all that, the family also may be tested. And that is a free testing for them. Of course, there are many issues in between which you have to tackle, but these all come under direct benefit.
Well, I have a different opinion on that. That if otherwise I cannot afford, okay, and it is because through the clinical trial I am trying to access that. In that case, I am vulnerable actually. So
you are vulnerable. All patients are vulnerable, actually, from one angle or the other. It's a relativity. Now, for example, a 16-year-old schoolgirl has melanoma, and she needs treatment for that. Just because you say the distributive justice, selection of participants, you cannot take because she has a BPL card with her. People will blame me if I take you. Not like that. She has every right to be included in the trial if she satisfies the inclusion criteria.
Absolutely, yes.
Yes, this was a very stimulating discussion from all our esteemed panelists. And I hope that this will be of great benefit to all our listeners. So I hand over to Shambho to come out with the conclusion of this beautiful workshop today.
No, thank you, madam. I think this panel discussion itself become a concluding session for today's GCP workshop, and I'm really thankful to you as a moderator and the wisdom of Professor Nandini Kumar, Professor Santanu Tripathi sir, Professor Sucheta Banerjee Kurundkar, and Professor Avijit Hazra sir, along with Professor Shantanu Tripathi madam. All had given their opinion, and I think those comments are really important for all of us who are interested in doing clinical research. So thank you once again, all the respected panelists who were there and our faculties. I am requesting all the delegates. I hope you all had submitted the post-test question answers. So again, I am requesting within another 5 minutes, please submit those. And because those post-test submission is absolute necessary for the certification also. So with that, may I invite Professor Nandini Kumar, Madam, because you are one of the most senior person today, and you were there with us from since afternoon. And your take-home message for our delegates and for us, Madam.
My pleasure.
So, if you have any comment, Madam, for our delegates.
Actually, I mean, all the talks were very stimulating. I would like to hear that once again, because learning curve is always there, you know, throughout your life. It's never that you know everything, every angle. So it was very useful for me also. So I can understand that participants would have actually must have definitely benefited from all the talks. I mean, various, and I liked Dr. Pradeep's presentation very much. So clear, such a clarity, and just those points, you know, we just get into your mind just like that. Very good presentation.
Yeah.
And the others, of course, Sucheta's colorful presentation, and the others, matter of fact, simple presentations, your presentation, all presentations were good.
Thank you, madam. It is really inspiring for us because we consider you as one of the textbook of ethics in India. So,
no.
really thankful to you, madam, for being with us. Any final comment from Professor Santanu Tripathi, sir?
Yeah, I missed out the initial other sessions, but I am sure that you have got them recorded. So if the recorded this thing video can be available, we can go through them. Because I was busy in my routine job, I couldn't be present throughout the sessions. But I'm sure that given the galaxy of experts who were there, and I know each of them, their background and their wisdom. So I'm very sure that all the participants who registered for this event, they must have benefited a lot. It must have been a great learning experience for all of them. Thank you very much, and great to get this opportunity to be with all other resource persons in the last 1 hour. I have been there. Thank you very much. Over.
Thank you, sir. And I think Dr. Sucheta madam also had sent one message that I completely agree. She is the textbook of ethics, Professor Nandini Kumar. And she also had mentioned that Dr. Nandini madam is the reference point to any complex and simple queries related to ethics. So we must admit this, and we are really thankful.
As far as I know, I
And
also
may I
have
ask
some
also,
dark
Dr.
corners where I don't know things.
So may I also ask Professor Sucheta Banerjee, madam, any comment from your side for our delegates?
Yeah, thank you so much. Thank you so much, Dr. Actually, I Dr. Silva, who I actually learn on the learn. So such kind of things should happen more regularly, you know, so that people exercise and have a strong focus. So
I think there is some technical glitch from your side. Couldn't hear you properly. So may I ask now, Professor Sondha Selvarajan, madam, if you are there, please give your final comments to our delegates. Sondha, madam.
Once again, I would like to thank Dr. Shambhu for including me in this workshop. And as Nandini madam was saying, it's always a learning experience. Every time I attend GCP workshops, I learn a new point. And it's a pleasure to see Dr. Sucheta's presentation, the way how she makes GCP related presentation very, what to say, fun-filled and easy to understand. So I hope the participants must have benefited from this. And as everybody was saying, I also would like to thank Nandini madam, because most of the things I have learned from Dr. Nandini and Dr. Vasna Swami madam. So they were the pillars of our ethics committee once upon a time, and like we have learned from them. So I'd like to thank Nandini madam also on this occasion.
They
Thank you,
were
Dr.
very
Shambhu.
good member secretaries also. I must say that also.
Thank you, madam. Now, may I ask also Professor Nandini Chatterjee, madam? You are one of the pillar behind us. So can kindly give your
chocolate வேணுமா பிஸ்கெட் வேணுமா பேரத்தை போடக்கூடாது சரி நான் கொடுக்குறேன் ஆனா அதுக்காக நான்
Actually, thank you, Shambo. What I would like to really mention is that the Association of Physicians of India, West Bengal chapter, has newly formed a wing, which is the Physicians Research Foundation, just like its headquarters. And our Dr. Shambo Shamazdar and Dr. Uttam Kumar Pal, they are the pillars of this Physician Research Foundation. And it is from their enthusiasm that we have been able to conduct this workshop on good clinical practice with this galaxy of esteemed teachers, I should say. And on behalf of API, we would like to thank all of our esteemed panelists and also the delegates whom I'm sure they have benefited and who will be certified after completing this course. And I would also say that Shambo should take up more such endeavors in future under the banner of API PRF, so that research, learning about how to do research becomes more easy for our postgraduate students and members. So thank you, Shambo. And this was a wonderful and very meticulous, well planned and worked out workshop. And I wish you all the best.
Thank you, madam. Just because Nandini madam is there, and I think we have a plan actually under the banner of Forum of Ethics Review Committee of India, FARSI, which is a very esteemed organization who guide different ethics committee across India. And we are planning for a short CMEs focusing on the critical ethical issues. And very soon, I think we will organize under Nandini Kumar madam's guidance one CME, and we may have collaboration with API West Bengal branch also, API, so that we will get more physicians with us. So thank you all. So we have to conclude today's meeting. And at the onset, I also want to thank Clarinet for giving us this digital platform and making these events very smoothly. I am assuring all the delegates who are attending that you will get the certificate. Your post-test will be evaluated, and with due course, you will get the certificate definitely. So thank you once again. So pranam to all respected faculties, respected panelists, and our respected delegates. So thank you. Jai Hind.
Thank you so much, everyone.
Thank you.
Thank you.
Bye.